Hello, everyone. My name is David Armstrong, and I'm the Director of the Health Workforce Tactical Assistance Center. Today's event is entitled Using CMS Data for Health Workforce Research. Now, if that's said, I'm going to go ahead and turn this event over to our guest moderator, Janet Coffman. Janet is from the University of California, San Francisco. Janet?
Yes, thank you very much, David. And in addition to being on the faculty at University of California, San Francisco, I'm Chair Emeritus of the Academy Health Workforce Interest Group, which has partnered with the Health Workforce Technical Assistance Center to put on this webinar. The mission of our interest group is to improve health and healthcare by promoting research and disseminating evidence that informs health workforce policy and practice. Every Academy Health member is welcome to join our interest group and to use our listserv to share information about health workforce research, postdoc opportunities, faculty positions, reach out, seeking advice on how to do research. And our group is currently chaired by Xiaoqu Hu of the Association of American Medical Colleges, and our vice chair is Deborah Goldberg, faculty at George Mason University. And you can contact either of them at the email addresses on your screen for more information about the interest group. As with all of the Academy Health interest groups, we will be having a session at the annual research meeting. Our interest group session is July 1st. I believe that's the Monday, 11 a.m. to 12:15 p.m. Eastern Standard Time, because we'll be in Baltimore. And the topic is implications of Dobbs versus Jackson on the reproductive health workforce. And so if you're attending Academy Health, we look forward to seeing you there. We are going to supplement that session that's very content heavy with a social and networking event on the evening of July 1st from 5:30 p.m. to 8 p.m. At the Pratt Street Ale House, which is within walking distance of the convention center. And this will be a multi-IG event that the Health Workforce Interest Group will be hosting with the long-term services and supports and the ERGNI, which I believe is an interdisciplinary research group on nursing. So please join us for both of those events if you are planning on coming to Academy Health. We're also in the process of recruiting new members for the advisory committee for the 2024-2026 term. Our members, we rotate. And so applications are going to open soon. So if you are part of the interest group and would like to take on a leadership role, please apply. We'd really like to have you serve on the advisory committee. And today's webinar is part of our series of webinars. And this is our way of keeping in touch with Academy Health Health Workforce Interest Group members throughout the year, as well as reaching folks who maybe aren't Academy Health members, but do health workforce research and are really interested in learning more about it and how to do it. And today's webinar is really, I would say, more on the how to do it, and that our presenters are going to be talking with us about how CMS data, Centers for Medicare and Medicaid Services data, can be used to conduct health workforce research. And our panelists are Professor Elizabeth White from Brown University. She's Associate Professor of Health Services and Policy and Practice at Brown School of Public Health. And our second presenter is Professor Uli Muench, Associate Professor of Behavioral Sciences at the School of Nursing at University of California, San Francisco. Both of them have a lot of experience using CMS data for health workforce research. And I think their presentations and their experience is going to complement one another nicely, because they've used these data sets to address different members of the workforce and different settings in which care is delivered to Medicare and Medicaid beneficiaries. So without further ado, I'm going to turn it over to Betsy and Uli to give their presentation.
Thank you so very much, Janet, for this introduction. And first of all, we'd like to thank all the organizers for inviting us. This is definitely a topic that Betsy and I deal with on a day-to-day basis, and we're excited to talk to you about this today. And maybe just to say upfront too that this is this is considered a primer to this topic. So after this, you might certainly need a more detailed, in-depth exploration of additional information. But to get us started, I'm going to share with you the agenda, which we'll start with how to get started with CMS data, the introduction of the Medicare program, and then we'll talk about a general overview of Medicare data files. We'll focus specifically on the carrier file, the Part D file, and the National Plan and Provider Enumeration System file. We will go through the data access options and provide some research examples and methodological considerations for you, followed by Q&A. And Betsy and I will trade on and off through this webinar. So as an introduction to Medicare, Medicare is a federal social insurance program that was introduced in 1965, and it provides insurance to individuals 65 years and older and disabled people. And it's a considerable share of the federal budget, about 15%. The program has been growing over many years now. On the left-hand side, you'll see the Medicare eligibility criteria, which in 2020 was at 62 million beneficiaries. And this is just a breakdown by age and disability. And on the right-hand side, you see the growth of the Medicare Advantage program, which has also steadily been increasing. In today's webinar, we won't be covering so much Medicare Advantage, but just to know, for you to know that this is also a considerable size of the Medicare program. Medicare consists of Part A, B, D, and C. In Part A, it includes hospital insurance, which covers skilled nursing facility and hospice. In Part D, the medical insurance part, we have doctor's office services and hospital outpatient services. Part D is the prescription drug coverage that has all the outpatient drugs, no inpatient medications are part of Part D. And then Medicare Part C, which is the Medicare Advantage part that I was just mentioning to you, which includes also Part A and B, and very often also Part D. And with that, I'm going to pass it over to Betsy.
Thank you, Uli. So we should also note, today we're just talking about Medicare. There are researchers who use Medicaid data as well. That's kind of a whole separate can of worms. So we're focusing today on Medicare data. So it's really important when you're thinking about using claims data that you always remember that claims data reflect billing. And that's different from using, for example, electronic health record data, where you're actually capturing inputs of actual clinical documentation occurring at the time that services are rendered. Claims data are kind of on the back end. So somebody renders a clinical service and then they submit a bill for payment, and that's what you're actually measuring in the data. So by and large, most of what you're capturing in claims data is more or less going to represent the actual clinical services, but there's lots of context and kind of nuances that you have to think through, and that'll vary depending on which claims files you're using and what your research questions are. So things like, different payment models, quality incentive payment programs might influence how data are captured in the claims data. So for example, if a clinician is operating in a risk-adjusted payment model, they might be incentivized to document certain conditions in certain ways because of the payment model. Another important thing to think about, particularly if you're working with nurse practitioners and PAs, if you're physician assistants, if you're interested in that population, is that because of Medicare payment for NPs and PAs, they're paid less than a physician. So sometimes NPs and PAs will bill as incident to another physician or a physician in their practice so that the practice can reap a higher reimbursement. So it's these kinds of little nuances that you just have to be very cognizant of when you're putting together research questions. Next slide. So this is just kind of a summary of some of the key claims files that are available. And again, this is sort of broken down by the way that Uli went through it. It's really important to tie each data file back to the aspect of Medicare in which pays for the services. So at the top here, we have the enrollment data. So these are all beneficiary level summary files. So the most important piece here is the master beneficiary summary file. This is a beneficiary level file that captures demographics, birth and death dates, zip code, if the person's enrolled in Medicaid, if they're enrolled in a Medicare Advantage. The MBSF is kind of the file that you're going to use regardless of what other claims files you use. Then there are a series of chronic condition indicators, and there's actually two different chronic condition categories. There's chronic conditions and then other chronic or potentially disabling conditions. As of 2017, there are 30 chronic conditions, and then I think it's 40 in the second category. That's CMS codes. And so each condition has its own algorithm that has a certain look back period across specific claims files in which CMS looks for certain diagnosis codes across different claims files, and then they create indicators of a chronic condition based on those algorithms. And you can go to, I have the link here for the Chronic Condition Warehouse website. You can get all the methodology for those conditions there. They're very useful. We use them all the time to identify patient populations. So you'll have both the initial flag of the condition and then also annual indicators for the conditions. There's also the cost and use file, which if you're interested in kind of overall utilization, payments for services, that's a file that can be useful. So in contrast to the enrollment data, which is all at the beneficiary level, all the other claims files are at the level of the actual episode of care. So looking at Part A, first we have MedPAR, which is a combination of hospital inpatient claims and then also skilled nursing facility Part A claims. And MedPAR is a combined file, but you can also get the inpatient and the skilled nursing facility files separately. Then there is the outpatient file, which is institutional outpatient claims, including the emergency department. So this is important if you're interested in looking at processes or outcomes of care related to ED use. If a patient goes to the emergency room, but they're not admitted to the hospital, they won't show up in the inpatient data. They will only show up in the outpatient data. So that's a really important file for that. And then home health, hospice, any of those episodes of care that fall under Part A, there are separate files for those as well. Part B, the main file is the carrier file. We're going to go into that in quite a bit of depth, but there's these are claims that are submitted by clinicians and organizational providers. Part C, as Uli mentioned, this is the Medicare Advantage program. So Medicare benefits that are administered through private insurance companies for a number of reasons. So there are a whole series of files that you can use to study Medicare Advantage, and there are a lot of researchers that kind of specialize in that. But there's a whole set, those are complex data to use, lots of limitations, both because some of the data that the private insurance plans have is proprietary, and there's only certain things that they're actually required to report to CMS. So if you're working with, if you're interested in the MA population, you really want to work with a researcher that has a lot of expertise and experience using those data. And then finally, Part D is the prescription drug data, and Uli's going to go into this in quite a bit of detail. One important thing about Part D data is you can measure people both under fee-for-service Medicare and under Medicare Advantage, because these are data that are submitted by the Part D drug plans, and regardless of whether they're attached to an MA plan or it's just fee for service, they're still required to submit into the drug event file. And then there's a lot of supporting files for Part D data as well that Uli's going to talk about in a little bit more detail. Next slide. So some other important additional files to be aware of if you're interested in two specific populations, one is the nursing home population, the other is the home health population, are the minimum data set and OASIS. So the minimum data set is standard clinical assessment data that's collected at regular intervals on all residents of CMS certified nursing homes. And this is important because in nursing home, there's two populations of patients. There are people who are there under their post-hospital Part A short stay, and then there's the long stay population. So Medicare does not pay for long stay custodial nursing care. So you can't measure you can't even identify a long stay nursing home resident based on Medicare data. You have to link it into the minimum data set. So if you're interested in nursing home population, you definitely need to use the MDS. OASIS is kind of the equivalent of MDS, but for home health care. Next slide. So if you're just kind of starting to get oriented to CMS data and just trying to figure things out, the best resource is ResDAC. So ResDAC is where you is the coordinating center for CMS data. It's how you access CMS data. And they have excellent data documentation. So basically, if you want to learn about the master beneficiary summary file, the best thing you can do is just Google ResDAC master beneficiary summary file, and then you'll come to this screen where you'll find the data documentation, and you can see, and you'll have a full list of all the variables. And then if you can see down at the bottom here, there's hyperlinks for each variable. You'll be able to see the methodology and the source data and all the details that you need to understand what fields are in the data. So ResDAC is the most important resource as you're starting to get up and going with CMS data. Next slide. So I'm going to talk a little bit about the carrier file. So again, carrier file is Part B, Medicare Part B fee-for-service claims. It's important to note that carrier claims, well, if you try and, the carrier file is a very large file because it's all individual clinicians and also outpatient institutional providers that are billing for this. So there's lots and lots of episodes of care. So if you want to access 100% carrier claims for the entire Medicare population, the only way you can do that is via the VRDC. And we're going to talk in a little bit about what the VRDC is. But a lot of academic institutions that purchase carrier claims, they only purchase a subset of the data. So most institutions will either purchase a 5% random sample of all Medicare beneficiaries or a 20% random sample of all Medicare beneficiaries. Alternatively, you can request 100% carrier claims for a subset of beneficiaries. So for example, we have a study where we have a sample of Medicare beneficiaries with Alzheimer's disease and related dementias who died between 2015 and 2018. So for that subset of the Medicare population, we have all of their carrier claims. So there's two ways that you can order the carrier claims. And yeah, so again, it's both clinicians and organizational providers. So like lab and radiology providers are in there, ambulatory surgical centers. So you have to do a lot of manipulation to the data if you're specifically interested in clinicians to get to get your sample down to the clinician level. Next slide. So these are some of the kind of key variables in the carrier file. And these ones on the screen right now, these are primarily the ones that you use to classify and identify clinicians. So the National Provider Identifier number, the NPI number, this is a unique provider identifier. There's both clinician level NPIs and there's also facility NPIs. So that's a key identifier for identifying healthcare providers. Another important one is the tax ID. So if you're trying to understand something about practice characteristics, clinicians that work in the same practice, then you can use the tax ID to link multiple clinicians. Provider specialty code. This is, so for physicians, you can actually see physician specialty. So if someone's internal medicine, family medicine, cardiology, what have you. For other clinicians, the provider specialty code doesn't have specialty designation. So for example, nurse practitioners. I'm a nurse practitioner. I'm an adult geriatric primary care nurse practitioner. I appear in the data only as a nurse practitioner. There's no additional specification. So for other clinicians who are not physicians, you have to use a taxonomy code. And Uli is going to talk a little bit more about this in detail. As of October 2023, there's actually taxonomy code in the carrier file. But prior to this, you would have to actually use NPPES data, which is NPI data, to extract that information if you wanted specialty information on these other clinicians. So Uli is going to go into a little bit more detail about that later. Next slide. So some other important variables, these are typically used to limit your study sample to a population of interest. BETOS codes, Berenson-Eggers type of service codes, these are codes that allow you to identify type and location of visits. So on the right here, these are examples of evaluation and management BETOS codes. So you can see here that there's different codes for both where the visit is occurring. So office, hospital, emergency room, a nursing home, and then also the type of visit. So it's a new patient, an established patient, and whatnot. So these are really important for, if you wanted to get to a primary care, looking at primary care visits, you're probably going to be limiting to office visits, for example. And then also, you'll typically use the Healthcare Common Procedure Coding System, or the CPT codes, if you want to, again, limit down to like certain types of visits. Those are very important. And then finally, place of service codes. Those get a little messier, but oftentimes you'll use those in combination with the evaluation management, or I'm sorry, with the BETOS codes to identify site of care. So nursing home, office, hospital, whatnot. So these are some of the key variables to be aware of. Next slide. And then I won't say too much about this, but just to be aware of it. So the Medicare Data on Provider Practice and Specialty file, this is the MDPPAS. So this is aggregate provider level data that CMS creates based on the 100% carrier claims. So remember what I said, most researchers don't have access to 100% carrier claims. So if you want to measure attributes of a clinician, you would be doing it based on only a 5% random sample or a 20% random sample. So CMS builds this aggregate data file that you can actually purchase, and then you have attributes of either the clinician or the tax ID. There's two identifiers in there, and people can use that for a number of different things. Next slide. Ulrike.
Thanks, Betsy. So talking about Part D now, which you remember from the beginning, is another key part of Medicare. And we are focusing really on variables that you might want to use as a health workforce researcher. So we've just highlighting a number of variables in all these files, but the National Drug Code is the one that identifies what type of prescription a patient received. The provider identifier, again, is obviously a key variable for us if we want to understand anything about provider prescribing. And then other important variables are the service date, day supply, quantity dispensed, number of fills, and also drug cost and payer information. And Part D comes with a series of additional supporting files that are sort of collectively known as the Part D characteristic files. They include a drug characteristic file, where you can get additional information on the medication. You can get additional formulary information, step and tier on the formulary file, a pharmacy characteristics file, which gives you information on what type of pharmacy order was used and where the pharmacy is located. There are plan characteristics as well on the type of plan, the plan identifier, and coverage limits, for example. And the prescriber characteristic file, which again has taxonomy and practice location. So you see here again the prescriber sort of characteristic piece popping up. And some considerations that you want to keep in mind when you think about what characteristic file you might need is that there is a cost for each of these. It's not as high, but it adds up quickly if you need it for more than just 1 year. Some of these data files are not available for every year, but that is often because during that year, that variable may have been part of the Part D main file. And then with the prescriber characteristic file, there is nothing in this file that you could not also get for free from the NPPES data. In fact, I believe this is populated from the NPPES data, which I'm going to talk to you about next. This file is also known as the NPI downloadable file. It contains all NPIs for all clinicians who have ever registered for a national provider identifier. It also includes organizational NPIs. This file is updated weekly and monthly, and each updated file contains the most current information from NPPES. Historical downloadable files are available, but are not maintained. So for example, if someone no longer maintains a license, we can't really see if that is still accurate information. This is a very large file, and some of the key data elements that you will probably want to pay attention to is, of course, the NPI to be able to identify providers, the taxonomy code, and I'll talk more about that in a minute, the provider practice location, gender, board certification, hospital affiliation, medical school and graduation year are some other interesting variables, but I have found that often they are only available for physicians and not for other types of clinicians. This file is typically used in conjunction with the free Medicare taxonomy crosswalk file. And this file helps us to crosswalk between the Medicare specialty code that Betsy already mentioned earlier and the clinician taxonomy code and the associated name with the specialty for the taxonomy code, because as you'll see a little bit later, there are hundreds of taxonomy codes, and we really need to know what this taxonomy code belongs to. And taxonomy codes have a lot more detailed information than the Medicare specialty codes. And I'll pass it back to Betsy.
So now we're going to talk a little bit about how to access data. So when you're talking about using the data, first it's important to understand the difference between different types of files. So public use files are aggregate data that are available for free. They're generally divided or downloaded off the data.cms.gov website. And they're just that, they're aggregate data. So they're at the hospital level, the nursing home level, the clinician level, but there's kind of, limited data that you can get beyond that. A limited data set is a patient level data or beneficiary level data, but it's de-identified. So for example, you don't like dates, you don't have like, you'll have age ranges as opposed to like specific birth and death dates. To use the LDS files, you still need to have a data use agreement, but they're less costly to use. They're less complex to use than the third category here, which is the research identifiable file. And this is patient level data. These are the most expensive data to use. You have to go through IRB approval, you need a DUA, but you have a lot of the granularity at the patient level. Next slide. And so this is all on the ResDac website too, and we'll share the slides so you have these, but just some important distinctions here between the LDS files and the RIF or the research identifiable files. As I mentioned, dates. So for example, if you're working with the MedPAR file, you only get quarter and year, as opposed to if you're working with a research identifiable, you'll actually get like the actual dates of admission and discharge from a hospital. And also you get more granular levels of where the beneficiary lives. And dates is kind of the main thing that distinguishes the two files. So important to understand these differences here. Next slide. So just a little bit about public use files. So again, these are aggregate provider data, and provider could either be the clinician, the hospital, a nursing home, the dialysis center. There's lots of different files that are available on this website. And from here, you can generally measure things like provider characteristics, quality measures, types of services that the provider renders. I'm listing some of the key files that are available, but I would encourage you just to kind of go and look around the website, depending on what you're interested in. They have aggregate like Part B data, Part D data, where you can get, kind of generic information about prescribers. Uli already talked about the MPPES data and the provider supplier taxonomy crosswalk. Some other data that are not derived from claims, but just that might be of interest to this group are the nursing home electronic payroll journal data. So this is electronic payroll data that every CMS certified nursing home in the country is required to submit. Lots of data in there. And then also care compare files, provider of service files, lots there to look through. So next slide. And just to give you this is just kind of a general overview of the CMS website. So basically you can go in, you can kind of search what topic you're interested in, and then you'll see the different files that are available here. So this is the Medicare physician and other practitioners data set. You can get it at the geography and service level. You can get it at the provider level. And, you know, similar to ResDoc, one of your first things that you want to look at is the data dictionary, just to kind of orient yourself to what kinds of variables are available. You can also look at the methodology. You know, every data file will have those links. And then down at the bottom here, this is just a screenshot showing, you know, how you access the actual data files. So you'll see the years of data that are available, and then you click on those links and you can just download the raw CSV files. Next slide. So when you do want to use the research identifiable file data, or the RIF data, there's a couple different options. So one, so they're kind of the no-cost options, which are currently available through the NIA data linkage program. So these are CMS data that are linked with data from available NIA-funded studies. So you can access all CMS files, but only for a subset of beneficiaries that are represented in those other linked studies. So you can't get like the entire Medicare population. We'll talk a little bit more about linkage in a second. The other option, the other two options are either your academic institution purchases data and houses it in-house. And with this, there's, you know, an initial cost to purchase the data, usually in the tens of thousands of dollars, depending on how much data you're buying across how many years. But then once the data is in-house, other researchers can reuse the data for just a $2,000 reuse fee. The other important thing with having data in-house is when you're talking about trainees, so PhD students, postdocs, they often will be, you know, able to access the data under, you know, a faculty member's grant, and that really, you know, has supported the development of health services researchers by giving trainees access to the data. The other option is through the Chronic Conditions Warehouse Virtual Research Data Center, which everybody just calls the VRDC. So this is a secure cloud environment that CMS maintains, where instead of like actually where the researcher actually has to purchase a seat, and then you have to renew it annually. And once you have that seat, it's not something that you can delegate to a bunch of. So if you have a doctoral student or a postdoc working with you, it's really hard to give them access to the data. So there's a lot of barriers to using the VRDC. It's extremely expensive. These are the current VRDC fees right now: $40,000 in your initial year of your study, and then $28,000 annually after that. So if you're not aware of the decision, so CMS just came out this year and said they were going to do away with academic institutions being able to purchase and house their own data out of security concerns. And they were going to make everybody go and work on the VRDC instead. And there was this whole outpouring of concerns about that, primarily for the issue of the cost of the VRDC, and then also that it would curtail access for trainees. So the current status, and we're not going to get too much into this discussion, is that CMS has put this change on hold at the moment while they're, you know, reviewing the financial structure of the VRDC and the current access requirements. But right now, I mean, people that do want to access the data, I mean, all the grants that we have going in at Brown are budgeting for the VRDC. So this is a huge kind of you know, more to come here, but for the time being, it's on hold, but we do need to expect that at some point, we may all need to be up on the VRDC. So next slide. So just talk a little bit about the linkage program. So this is a big initiative that NIA has adopted to try to increase access of data. So people who are using data from NIA-funded studies, like the health and retirement study, that's a good example, and they want to link that to CMS data. They can access that linked data for free on the linkage website. But very importantly, as I mentioned before, you don't get access to the entire Medicare population. You only get access to the beneficiary sample that are represented in that link study. So for HRS, it would be you only get data on HRS participants. So the data are free to access. You access it via a secure cloud-based environment, which is the Linkage Enclave, and you go through a DUA process, and you have to actually apply first to whatever the link study is. So you would have to apply to use HRS data. They approve you, and then you go through an NIA or data use agreement process. So this is another option, but again, there's limitations to it because it's only for a subset of beneficiaries. Next slide. So this is a list of the current studies that are available for linkage. So as I mentioned, Health and Retirement Study, NHATS, which probably a lot of you have used, are probably the most important ones that are on there now. There's more to come here. The other one that we'll just put in a plug because Uli and I are both involved with it is the National Dementia Workforce Study. And Uli, if you go to the next slide. So anyone that's interested in studying the dementia workforce, I would encourage you to go and take a look at this website. So these are surveys that are going to be going out to staff of nursing homes, assisted living, home health agencies, and then also clinicians, so physicians, nurse practitioners who take care of people with dementia. And there is going to be, so they're going to be getting survey data, and then all that survey data will be available on Linkage, linked to claims data. So that should be up on Linkage in like early 2025. So just to be aware of that. And next, back to Uli.
Okay, in this next part of the webinar, I'm going to talk with you through two research examples that kind of pull this all together in terms of where do we all get the the variables from what files, and sort of show you how this works in real world research. As a summary, I wanted to just provide an overview of the key workforce variables that are in the various files. So we've already talked through this, so we're not going to spend much time on it, but a key methodological piece here is that the combination of the NPPES free downloadable file in combination with the taxonomy code is basically the bread and butter by linking that to the carrier file or the Part D pharmacy claims to give you the any sort of information on providers. And so this is sort of a key piece to consider in whatever health workforce study you would be engaging in. And the two examples I'm going to share with you are opioid prescribing outcomes of Medicare beneficiaries that were managed by nurse practitioners and physicians, and then another example I'll talk about in just a little bit. So in the first research example, our research question was, is the type of provider, and here we wanted to understand nurse practitioners versus physicians, associated with opioid prescribing patterns in primary care? So we have types of clinicians, and for setting, we are interested in primary care. And this is by no means going to be a talk on the actual research studies, just a few key methodological things to highlight that I hope give you an understanding of how we went about conducting the study. So our setting is primary care. Our clinicians are nurse practitioners and physicians. And we will be using the master beneficiary summary file, which has all the enrollment information, as Betsy mentioned earlier, demographics, chronic conditions, Part A and B, which allows us to use also other comorbidities and do risk adjustments like the Alex Hauser. And we will use, obviously, the Part D data to obtain pharmacy claims. And our unit of analysis here is the beneficiary. So how do we then identify primary care NPs and MDs? So what we will do is we'll use a combination of Medicare specialty codes, which for NPs is 50, and for MDs, family medicine and internal medicine. And then we also going to use the evaluation and management claims specifically the M1A and M1B, which are the specific locations office visits for new and established, the bricks and I forget what the bricks and what is it, Betsy?
Betos codes.
Thank you, the Betos codes, to focus on this combination of types of clinicians plus the setting to the best we can focus on primary care. In addition, you obviously always have to think about your population that you're describing. So, obviously specific diagnosis codes, but also we typically use a set of enrollment criteria to just make sure our population is stable throughout our study period, that they don't go in and out of Medicare. And so we generally look for continuous enrollments in Medicare Parts A and B, or also D if your study focuses on prescribing, and other things like hospice claims or whatever else you might have for inclusion/exclusion criteria. Here's an example of the opioid outcomes that we used in our study. I won't be focusing on this since this is just specific to this study. But the key piece now is, how are we going to be assigning patients to a primary care provider? For the research question, is the type of provider a nurse practitioner or physician? We must make some decisions in terms of who did this person mostly see, a nurse practitioner or a physician. So this is called attribution, or attributing patient to providers. And why this is so important is, right, if we have a patient, this is basically just a schematic of the real world complexity of primary care. The patient might have all sorts of chronic conditions, and they're not going to just get seen by physicians and nurse practitioners, but also by specialists who might be providing that primary care. But again, we must make some decisions now and figure out how to assign these patients to physicians or a nurse practitioner. And so what we can do is we can use, again, the E&M evaluation services to assign patients just to physicians and nurse practitioners. And we want all the dotted lines here are going to be relationships with clinicians that for the purpose of our study, we will be ignoring. And there are all sorts of different approaches to attributing patients to providers or also practices. Here are some common ones, such as majority of visits, where patients are attributed to the provider or practice where they have had the majority of their visits over a specified period, which may not accurately reflect the primary provider if patients have many single visits to multiple providers. There's plurality of visits, which is similar, where we have the highest number of services or visits, but the minimum threshold must generally be met. And that ensures that the provider has seen the patient more than any other provider. There's also total cost of care associated with a provider or practice used for attribution. And that accounts for the financial aspect as well as intensity of care or services. And there are multiple other ways, but I would say the top three are the most common. And what are the takeaways of attribution? So we need this when we want to examine the effects of provider characteristics, such as the provider type or the specialty on beneficiary level outcomes. But you don't need this if you, for example, have an analysis at the prescription level. There are many different approaches, and they require specification of cut points or thresholds that can be somewhat arbitrary. For our specific study, we actually use cost attribution. Back at the time, that was the common method to use. Nowadays, I would probably focus on plurality of services, but here we calculated the total portion of E&M paid amounts and assigned clinician with the highest proportion of that amount. And we applied a 30% threshold to ensure an established relationship with the clinician. And after all that is done, you would then be able to look at outcomes of primary care nurse practitioners that were attributed to beneficiaries. And we don't really need to talk about these results. It's just an example of how you get from your methods to your to look at and measure your outcomes. In the second example, we are going to talk about rural-urban prescribing patterns by primary care and behavioral health providers in older adults with serious mental illness. Again, some of the key methodological points that I'd like to highlight here is that we'll use the carrier file, the Part D file in combination with the NPPES data. And now for clinicians, we would like to look at primary care clinician, but also behavioral health specialist providers, in addition to the clinician type, such as physician, nurse practitioner, and physician assistant. Our unit of analysis in this example was a prescription claim, so we don't need to worry or think about attribution for this example. And the key piece I'd like to highlight here is how we can use the NPPES file together with the taxonomy crosswalk file to get a more nuanced view of types of clinicians and their specialty beyond what I just showed you in the first research example. And this is a snippet of the NPPES file. It is a really long file, but this is what it looks like. And I pulled this, these screenshots for Medicare Specialty Code 11, which gives us the internal medicine. These are all the subspecialties for physicians who work in internal medicine and another subspecialty. And on the left-hand side here, you see the taxonomy code. Similarly, in the bottom right, I've pulled for Medicare Specialty Code 50, which is the nurse practitioners, all the subspecialties that are actually available here for nurse practitioners. So if we just use the Medicare Specialty Code, we would just be able to identify nurse practitioners, but not their specialties that they were trained in. And so for this particular study, we were also including specifically psychiatric mental health nurse practitioners under this taxonomy code, which allowed us to then group clinicians by primary care as well as behavioral health. And that allowed us then to summarize various medication categories by rural urban status, but as well for primary care and behavioral health clinicians, but not just by type of provider, right? We can now have behavioral health clinicians, such as nurse practitioners, coded in this way as well. And here you can see sort of this combination in action, where we then can break this down by primary care MD, primary care APRN, other primary care providers, and then behavioral health specialty physicians, as well as APRNs, as well as others. For example, this could be also psychologists. And one thing to note here for physician assistants is that specialty information on physician assistants is generally not available. So we are going to include that, include physician assistant under primary care. And that concludes our example overview here of how you can combine the type of clinician with also the specialty information for your health workforce studies. And I think I'm going to pass it back to Janet.
Yes. Thank you very much, Uli and Betsy. Lots of really important information about these complex data sets, about how to access them. And thank you, Uli, for the research example, because I think that makes it more concrete. I'm going to kick off the question and answer with a question that's been suggested to me by our workforce interest group chair, Xiaochu Hu. But for everyone else, please put your questions in the Q&A box. We've got about 10 minutes and we want to hear from you. So Xiaochu's question is, could you please talk about what information is available at the provider level in the data? And I think you did talk about that a bit for the NPI file, but maybe run through again as to what details are available about providers in the various files.
Yes, that's a good question. Thank you. So there is no provider information beyond NPI on the actual Medicare data. The way how we obtain some of that information is from the NPPES data, which has the gender, the degree type, if it is available, and when they obtained the degree. The prescriber characteristic file also has gender, but as I mentioned earlier, that comes from the NPPES data, and since the data is free, and if you're able to link it, that's what most providers do. So it is somewhat limited, I would say, the information that is available on the characteristics of the providers.
And then there are the other kind of the aggregate level files that CMS builds that we had mentioned. So the MD PPAS data, and then there's the 2 public use files for Part B and Part D. So for example, I'll just give you an example. So in nursing homes, there's kind of a body of literature around, they're called SNFists, or nursing home specialists, which was analogous to a hospitalist. So a hospitalist is someone who bills 90% or more of their claims in the hospital. And there's a thing that we call it SNFist, or nursing home specialist in the nursing home, which is someone who bills 90% or more of their claims in the nursing home setting. So if you were just to use a 20% random sample of the carrier file, you only have a subset of an individual clinician's claims. But that MD PPAS data is aggregate clinician level data based on 100% carrier claims. So the people that try to identify SNFists in the nursing home, they use the MD PPAS data to look at total services and proportion of total services that are delivered in a nursing home, and they are able to designate a clinician as a SNFist based on that file. So it's a combination of the kind of demographic characteristics, training characteristics from the NPI and PPES data, and then also some of those aggregate files, those are also available.
Thank you very much, Uli and Betsy. Next question. Do you validate the NPI data from the NPPS system before using it in any research? And if you do, could you please describe your validation process?
Another really good question that has in general been sort of circulating in the research community, I would say, with regards to the validity of the NPIs available in the NPPES, because of this file not being updated as clinicians move through the trajectory of their through their training. And so I have no way of validating the file, unfortunately. Maybe Betsy knows more about this, or someone else, but I believe that some other researchers might be working on trying to validate it, but I'm not aware of any official validation studies that have been done.
Uli is my go-to expert on the NPPES data, so I defer to her.
So Uli, I think that's right. I mean, I do think there are, how this potentially could be done is if there are states in their own survey, in some states like California, their licensing board survey, if those are collecting NPIs, then it would be passable to link the 2 files, and to the degree that those state agencies are collecting data on the same variables that we see, well, are the characteristics the same? And one thing I'm always very interested in is the location the same? So there might be some ways to do that, but I don't think it's been, Uli's correct, that I don't think it has been done. Our next question, person says, sorry if I missed this, but can a physician assistant specialty be identified using the taxonomy codes? Could you distinguish let's say a physician assistant who's working in a primary care practice from one who's, say, working in a surgical practice?
Unfortunately, I don't believe that is possible, which is also related to, I think the training is not organized by specialty information. So obviously, as a physician assistant decides on where to work, they develop specialty knowledge in certain specialty clinics. So unless we know where they are working and how long they have been there, which might be possible by looking at where are their claims showing up, are they showing up in a clinic of certain types of patients, for example, where you can maybe come up with another way of how you might want to quantify the expertise that a physician assistant has. there's no other way to develop subspecialties for a physician assistant.
Yeah, and so the NPI is tied to like board certification. So like a key difference between nurse practitioners and PAs is nurse practitioners do have board certifications in different specialties, and that's reflected in the NPI versus I know there's a couple of like board certifications that PAs can apply for, but by and large, there's just like the one board certification. So, but just like Uli said, like you could post hoc go in and based on CPT codes, based on, place of service, where they're actually practicing, make some, come up with an algorithm to, assess the practice of a physician assistant. They're working in a surgical practice or primary care, but you'd have to do that work yourself.
Yes, and thank you, Betsy. And we do have one of our participants, has validated with other data sets. So this person has used national data that contains NPIs and especially information for physician assistants, and merged that with the CMS data. So in other words, grabbing having this person had access to a national data set on PAs that had NPIs, and then was able to do that, and from that other national data set, use the specialty that was reported. So that's how it could be done but you would have to access and bring in another data set.
That sounds terrific.
Yeah, kudos. Would like to learn more. Let's see, one more question. And so this participant asks, does the NPI distinguishing between PAs and NPs? I think the answer is yes.
Yes.
Okay, other questions that folks have? I am just kind of curious, the answer might be no, but whether there are any other examples of data set linkage programs like the ones, Betsy, that you described with the National Institutes of Aging. I mean, that just strikes me as a really, helpful resource for people who have National Institutes of Aging grants, and also potentially I think it does reduce maybe the cost of funding grants through NIA for projects that use Medicare data. Just wonder if you know of any others. I mean, I think maybe I'm wrong, but maybe SEER has some linkage with the Medicare data.
I'm not really familiar with SEER data. Uli, are you? Or
the SEER data is, I think, a cancer level data set with additional cancer information, but I think it's just additional data that can be merged. I don't believe it's like an enclave.
Okay.
Yeah, I think you would have to purchase the data separately and then go about the linkage. So the unique thing about the NIA linkage program is that you apply for whatever the NIA funded study is, HRS, NHATS, National Dementia Workforce Study, and then basically linkage gives you a cut of CMS data for the beneficiaries represented in
got it.
HRS and HATS. The other example I'll plug, just because I'm part of it, is Long-Term Care Data Cooperative, which is nursing home electronic health record data. So that I think we have, it's like 1.4 million unique nursing home residents that are represented, that we have electronic health record data on for the Long-Term Care Data Cooperative. And that's going up on linkage, and that's all linkable to claims. So someone can apply to the Long-Term Care Data Cooperative for the EHR data, and then also apply for the Medicare data, and they would access that all up on linkage. So I know NIA is definitely investing a lot in that infrastructure, and there will be more and more studies that are going up there. So people should definitely be aware of that resource. There's things to work out with anything new, but definitely be aware of that resource.
Okay, well, we are at the hour, and I am seeing no more questions in the Q&A forum. So I would once again like to thank Betsy and Uli for their presentation. Really appreciate it.
Well, thank you, Janet, and thank you, Betsy and Uli. That was a wonderful presentation. A lot of really good quality information for people.